Hello, everybody. Greetings from Indian Medical Association. I'm Dr. K.K. Agarwal, past National President IMA and also President of Confederation of Medical Association of Asia and Oceania. I have with me Dr. Jay Krishnan, Dr. Sanchita, and others. Dr. Ramesh Datta, the Finance Secretary, has also joined the meeting. Our Chief Guest, Dr. Rahul Pandit, has also joined. We are lucky because he was finding it difficult to get connected for the program. So I'll request Dr. Ramesh Datta to open the meeting, the Finance Secretary.
Okay.
Hi, sir.
On behalf of Indian Medical Association, I welcome Dr. Rahul Pandit from Bombay, and our resource person is today's resource person is Dr. K.K. Agarwal, the past president of Indian Medical Association and chairman of CMAAO. I request Dr. K.K. Agarwal to formally introduce Dr. Rahul Pandit and then proceed with today's.
So Dr. Rahul Pandit is the Director Critical Care in Fortis Hospital, Mumbai. He has been actively associated with COVID right for its management. So we thought of sharing his experience in reduction of mortality in Mumbai, the present situation in Mumbai, and the protocols being used in Mumbai. In Maharashtra, Mumbai has been very active in the management, and Rahul is doing a great job, and he's also doing some specific job in building up cellular immunity. Everybody is talking about immunity, so he is trying to build up some work on building cellular immunity of a person. So because last night he called up and he said he had to visit somewhere. So I said it will be more of an interaction than of a PPT presentation. So Rahul, go ahead with your.
Thank you, sir. And my apologies. I'm in a place called as Sangli, and I'm not actually in Sangli city. I'm near Sangli city, so the network is very poor and patchy. I am not able to bring up my slides on the phone because they are just not getting downloaded. So I'll probably speak about this, and I'm really sorry for that. So in Mumbai, we have been basically seeing the peak since the last 7 or 8 months, though the cases have reduced since the month of November. And we have now got really only 400 to 500 cases coming up in most days. But September was the worst time when we actually had around 2,000, 2,500 cases coming up every day in Mumbai metropolitan region. What we did was we conducted a trial looking at a molecule called as thymosin alpha. Now, we all know that one of the problems with COVID is that it causes actual lymphocytes to go down. And that's a lot to do with your CD8 and your T cell, which basically don't get activated very quickly. And we know that the children are protected a reasonable amount of immunity from the thymus gland, which is present in an active child up to around 8 to 10 years of age. And they seem to have the least amount of symptoms. And if you look at that lymphocyte ratio, it doesn't fall down that much. So we decided that we were trying to see this molecule, which has been used in other form of cancer therapies, to see if it can actually activate our CD4 and CD8 and bring up the lymphocyte count a little bit early. And that's what we did. We conducted an exploratory trial. I would not call it as a proof of concept as well. An exploratory trial looking at around 15 consecutive patients. There is a trial done in China, and there is an ongoing trial in China. You're looking at the same kind of a protocol. So I sort of did not deviate from the protocol. The protocol was to select critically ill patients. Critically ill as per the ICMR criteria, those patients who are in ICU, who are having an organ failure requiring either high flow nasal oxygen or a ventilator, more than 50% FiO2, more than 50% oxygen with a PF ratio of less than 200. And that's what we actually looked at the patients. And what we saw is that when we started these patients on day one with the thymosin alpha protocol, which was 3.2 milligram to be given subcutaneously 3 times a day, we saw a statistically significant improvement in their CD4, CD8, and their lymphocyte counts. And that was seen by around 4th or 5th day. And by 7th day, it was statistically significant. There was also a conscious decrease in the cytokine markers in these critically ill patients, in namely CRP and D dimer. What did not change much was LDH And I think ferritin also was statistically significant, was just statistically significant. It wasn't really as robust as it was for the D-dimer as well as for CRP. I think this molecule basically helped us in understanding the role and importance of these CD4 and CD8, which sort of helps us into building up our cellular immunity and bringing up the T cells to sort of help out in recovery with this dreaded disease which we are facing through right now. And obviously, the question is that if why wait till they become critical? Can we not do this before? Because our average lymphocyte percentage was in single digits when we had these patients in ICU. So if we could actually act on mild to moderate patients, perhaps, or maybe moderate patients, perhaps we would actually stop them from progressing on to the severe patients. And this is how we started thinking about it. There is another trial going on with a colleague of mine, which Agarwal sir knows about, and we would be sort of shortly looking at the results. The results have been written up and are being given up for publication from my study. The other study is about to be completed, and I think it's an exciting molecule to look at. Obviously, it will have to be tested into a larger trial, randomized control, perhaps blinded, to see whether it actually makes a difference in the mortality or not. But it certainly has shown that the CD4, CD8, and the lymphocytes pick up when you give this molecule in a ratio.
So you picked up cases, all of them had a low TLC count?
Yes, sir.
How much, what was the average TLC count when you picked it up?
So
Absolute
the
lymphocytic count? ALC was?
average TLC was around, sir, 4,100, and the lymphocyte percentage in that was in single digits. I think it was 9.2% averagely, sir.
So is there any trial done on HIV, because that also has a low CD4 counts? Anywhere in the world, people have worked on HIV and seen that they also increases lymphocytes?
So not that I know of, sir. Obviously, it's a very interesting question. This molecule has not been tried into HIV patients yet. And obviously, the trial has not been done into HIV patients, and neither any of my patients had a coexisting HIV as well. So we don't
Any
have that
response on monocytes and on eosinophils?
No effect on monocytes and eosinophils. The neutrophils reduced and the lymphocytes improved, sir.
So those who are watching will go ahead with further discussion. Those who are watching this program, this virus, when enters the body, releases interferon, and interferon releases gamma interferon, that releases TNF alpha, that causes little bit of a cytokine wave or a cytokine. And the second time, if the interferon is not released, it ends up into a Th1 response. And in that Th1 response, initially polymorphs gets increased and lymphocytes gets reduced. CD4 are helper C types, CD8 are cytotoxic cells, and CD3 are the non-killer cells. And what Dr. Rahul Pandit is saying, it is possible to have a artificial thymus vaccine, something like you have a menopause. This can be called as a thymopause, that after a particular age, if your thymus is not there in the body, and if the body has never been uh, exposed to a new virus, then you can give thymus hormones, which can be synthetic, like you are giving with a synthetic messenger RNA. So you can create synthetic thymus hormones. One of them is thymosin alpha. There are others. I'm sure other thymus hormones will also come. And if you give them, they may be able to help. That's one. Number two, my second question comes is, Rahul, is that those people who says we have been infected and we have not produced antibodies. We have not produced antibodies. Theoretically, giving these types of thymosin help them in producing antibodies, more antibodies?
Wow, very, very interesting question again, sir. Theoretically, it would be interesting, probably possible, but needs to be checked up, sir. As I said, exploratory study needs to be done to see whether the antibodies produced in these patients were different to the other ones. Hello? Hello?
Yes, yes.
Yeah. So I can follow up as a follow-up study and see if I can actually get my patients to consent for a new study, the 15 patients, and see what were the antibody levels in them. I don't know that. So that would
So
be
if you can
interesting
pick
study to
up
do.
15 patients where this is given in mild cases and where in 15
Yeah.
cases where it is not given, we just have to check the antibodies level. And if we can see these cases produce more antibodies,
Yes, sir.
and this is a theoretical assumption for that.
I think
Number
it's an
three.
excellent assumption, sir.
Number three is anything else apart from thing which can stimulate thymus in the literature? Anything else in the world going on by which you can stimulate your thymus gland apart
No,
from
sir. No other molecule that I know of, sir.
any herb, any molecule, any diet?
Diet I'm unaware of. Molecule I'm pretty certain there is no other which is in the pipeline or which has been explored, sir.
Okay, so coming back to other aspects, what is the role of tocilizumab in what is the current role of tocilizumab in COVID-19?
So, sir, tocilizumab is losing its role more and more. We know that if you start supportive care and steroids on time in a hypoxic patient, you probably don't need to use tocilizumab. I haven't used tocilizumab in the last 4 months, 4.5 months. However, there could be a particular patient where there may be a thank you, sir, where there may be a requirement where the cytokine storm is just in place and it has happened. In those cases, maybe there might be some role to sort of use it, but often than not in the ICU when we are getting patients, we have not seen the need for that now. Whereas we understand the disease a bit more better than what we used to understand it before, sir.
So tocilizumab normally would take how much time to act?
Tocilizumab would normally take around a few hours to start acting, sir, and then the 24 hours would sort of go down. The level would go down.
And what about baricitinib, which is now been approved in USA?
Yeah,
Tocilizumab is a single cytokine inhibitor, that is a multiple cytokine inhibitor.
Yes, sir. So multiple cytokine inhibitors look promising again, but whether the need to give them is there or not, we don't know, sir.
So that is another thing. And what is the role of currently when we know that the virus is inactive after 7 days? The virus gets inactivated after 7 days. Virus is not alive. And say favipiravir and remdesivir both takes, how much time remdesivir takes to act?
So remdesivir, favipiravir, all of them probably to be given up when there is viral replication there. If once the viral replication time frame goes, which is 7 to 9 days, none of them have got any role to be used. And remdesivir probably, you may use it when again it should be probably used in moderate patients who are likely to worsen and become critical rather than using it in critical patients, which may be too late to use. First
So
of all, whether it has changed mortality or not is a big question. We have seen the 2,500 patient data from the WHO trial, which has not shown, but there's a huge amount of retrospective data, which again can be sort of looked at, and the proof of concept can be sort of drawn from there to see whether there is any role for remdesivir to be re-explored again.
So why I'm asking specifically is that, say, if favipiravir has a protocol of 14 days, when the virus is dead on 7th day, why
So
continue it for 14
most
days?
people are now giving 7 to 10, 15 days. This was sort of a not pharmaceutical, but based on pharmacokinetics and pharmacodynamics that they chose to use this. I don't think there is any difference whether you use it for 10 or 14 days. I think 10 days is probably as good as 14 days, sir.
But if you are starting on 7th day, then why continue for 10 days?
The starting on 7th day, you should not be started on 7th day. You should probably be starting on 3rd or 4th day. After 7th day, though, it's like almost no need to start it, sir.
Okay, coming back to plasma, this remdesivir, and then what about ivermectin in Mumbai?
So very less data about ivermectin and doxycycline as compared to the other two, but they seem to be promising. I think we need to have a good randomized control trial coming out to actually understand it a bit better.
When to give steroid and when to upgrade the steroid?
When to upgrade steroids?
Upregulate
Steroids, when you have hypoxia, we need to use steroids, dexamethasone, 6 milligrams, or even in India, we are quite comfortable using methylprednisolone 40 milligram twice a day, sir.
No, 6 milligram of dexamethasone will be equivalent to 40 milligram of prednisolone. Hello, I think he got disconnected. So we will come back to him with this question because he is at a place where the data is not there. So let Jai Krishna and Ramesh, let's interact with each other. We still have some time. Dr. Jai Krishna.
Yes, sir.
Yes, we can talk to each other till
Yes, sir.
he
Actually,
joins.
this is a very important point. The cell mediated by such a chemical.
So the issue was that
If it's possible, even patients, especially immunosuppressed.
go ahead. I think there's something wrong in the connection today. Everybody is getting disconnected.
Certain percentage of patients who will be so it will be ideal to have such a chemical and improve the resistance against the virus. That is one thing. And second thing is regarding management, the role of Torsmith's lab, etc., has to be revisited.
So what we have spoken till now is that if you have a very low absolute lymphocytic count, it is something like when you are treating a patient with chemotherapy and you have reduced polymorphs and that you built up the TLC level. Similarly, sooner or later, a drug is going to be coming, which will boost up your lymphocytic count. Now, such medicines may help in boosting immunity, short-term as well as long-term. These drugs may also help you in building a better immune response even after a vaccine, but the time will tell us. The second thing we were discussing was drugs like tocilizumab, which is a single cytokine blocker like IL-6. Then we have baricitinib, which is a multiple cytokine inhibitor working at the level of JAK-STAT pathway as a JAK1 inhibitor, which also takes 72 hours to act. And it will bring an end to the inflammation. That means if you have an inflammation and which is not getting under control, at that particular moment, you have two choices. The first choice with you is to upregulate the steroid dose. And the second is you can add baricitinib, which is an oral medicine available in India. The drug is given as a standard in resistance cases of rheumatoid arthritis, 1 tablet a day. Large number of rheumatoid arthritis patients are on this drug. So therefore relatively safe because it is approved by DCGI in India for rheumatoid arthritis. The same drug, if given, can block the inflammation within 72 hours, but not the thrombotic part for which you need to, if the patient has already developed a extensive microvascular thrombosis, in these cases, the results may be bad. So I'll ask Ramesh to start interacting. So for some time, I'll become now Rahul Pandit.
So for microvascular patients, we are giving low molecular heparin for that.
So we have three options there. In prevention, you can give aspirin. If the patient has developed as a slightly higher macrovascular state, we have 5 options. One is heparin, low molecular weight, prophylactic dose or therapeutic dose. The second option is with us is warfarin. Third is acetron. Fourth is dabigatran. Fifth is rivaroxaban. And sixth is apixaban. Now, these are the medicine on a case-to-case basis we can divide, either on therapeutic dose or on prophylactic dose.
Yeah.
If these also don't work, then the last option with us will be thrombolysis by either streptokinase, tenecteplase, or by giving them TPA. So these are the options available depending upon the D-dimer level, depending upon the coronary CT pulmonary angio, what type of a clots they have.
Mhm.
So when somebody asks me, how do we treat COVID-19? So when we treat COVID-19, we have three options. Option number one, we say is attack the virus. Attack the virus. That has to be attacked within 48 hours. The second one which comes is attack the inflammation. Early diagnosis and attack the inflammation, that is the second answer. The third thing which comes is attack the thrombosis. So if there is a thrombosis, attack the thrombosis. So if we attack at these three levels, each three of them will be, and the fourth one is recover the damage done. Whatever damage has been done, like fibrosis has happened, try to recover that. If there is a hypoxia, treat the hypoxia. If there is MI, treat the MI. So if somebody asks me, how do you treat COVID-19? Our answer will be, can I treat? So I can give you one slide which can explain everything. Let me see if I have that slide. So these are the questions. So these are the questions. Each question can be written into a full book. Each question can be written in a full book. Has the virus entered my body? Has the virus entered my body? So I check the antigen or the gene test. Okay. How much is the virus load? How much is the virus load? Is it a small viral load or a high viral load? So this can be done by how much is the virus load, which can also be done by a CT value. The third thing is, what is the modus operandi? Has it entered through the respiratory or the GI based on the clinical set? Is my body on fire? Is my body on fire? Check for acute phase reactant. That means fire means inflammation. Is the fire local or systemic? Is the fire confined to the lungs or it has entered the whole body? This is TNF alpha versus IL-6 dash CRP. Where else is the fire apart from lungs? Is it present in the heart, liver, eye, skin, blood, and GI? How severe is the fire? Quantitative CRP or quantitative IL-6. Has it damaged my organs? You say lab testing and imaging to check, has it damaged any of my organ? Is the damage reversible? It has damaged the lungs. Is the fibrosis reversible? Has the damage recovered or not? You say partially recovered, fully recovered. Has the debris been removed? Persistent antigen, ESR will tell you has the debris been removed? You say that this dead virus may present in the body. Has my inflammation recovered totally so that I don't get a re-inflammation, that is baseline CRP? Is there any clotting? Is there any clotting or a residual clotting? So, or residual clotting. Have I confirmed the culprit? That means RT-PCR, RAT test, CBNAT, TrueNAT. Has the virus gone? Have I developed the antibodies or not? And then thing is, will the virus come back? So these are the 16 questions in every patient asks. These are the commonly asked questions, concerns are these 16. Has the virus gone? Have I developed antibodies? Are they adequate? Will the virus come back? Will the virus or the inflammation come back? Public clots will come back. So these are the questions which I make when I get up at 2 o'clock in the night and then think about it right and then again sleep. So these are like things which have come in my mind, and this practically answers all your questions. So similarly, when you are treating, this is what you treat. If you answer these 16 questions in your treatment, how this is has, and then comes is how. The second slide will be how. How do I reduce? How do I remove my debris? How do I recover my damage? So for each, there is a clinical criteria, lab criteria, and a treatment. And that comes out of a full book. You can come out with a short kunji on this. Has it damaged my organs? Which organs? Have they recovered? How to recover? What medicine to give? What imaging to do? So there comes the role of whatever we are discussing here. We are discussing is here. When we say, is my body on fire? Is the fire local? Where? How severe is the fire? Quantitative, ARP, CRP, and absolute lymphocytic count. So here, how severe is the fire? I can say, should I use baricitinib? Should I use thymosin alpha? Number 7 comes. But so each treatment is incomplete unless I answer all 16 questions. I know when I entered my medical college, I was taught that a case file was seen where it was written patient was admitted with diarrhea, diarrhea stopped, patient died. So this shouldn't happen, that you treat one, but you ignore the other findings. So the patient, you say, oh my God, I've given tocilizumab, but I have controlled my CRP. But if you haven't controlled the clotting, the patient will die. Jai Christian, if you want to ask, because this slide covers this, all the answers.
Yes.
I can have full one-day conference on these 16 questions.
So how does the immunity in a viral disease like polio differ from that of immunity in COVID? Both are viral diseases.
Both are viral. Both of them are mucosal. Both of them are mucosal. Yeah. And mucosal immunological vaccines will not work more than 60%. So all mucosal antibody vaccines in the past have been effective only up to 60 to 70%. For the first time, they are saying mRNA can be 90% effective. Otherwise, up till now, all protein-based vaccines through mucosal have been only 60 to 70% effective. Therefore, they require redosing. Polio, therefore, was required multiple times to be given. Similarly, it all depends upon, say, for example, Covaxin, which India is bringing. I thought Covaxin should have been launched in August. That's my personal opinion. Covaxin should have been launched after phase 2. It should have been launched. All inactivated vaccines by history are less effective, but more safe and can be given on multiple occasions. So if India would have adopted that approach, by this time, things would have been different. That's my personal opinion on Covaxin. And now all vaccines which will come here in India, you will have only 2 choices. Either you will be given Covaxin, unless you want to buy it from the market. From the government perspective, they will give you either Covaxin or they will give you the Oxford vaccine. Oxford vaccine will cause more reactions than Covaxin. And if Covaxin also comes out to be 70 or 60% effective, that will take more advantage over the Oxford vaccine.
Oxford vaccine.
And sir, why these mRNA vaccines are said to be more immunogenic and more produces more inflammation?
You're giving a nucleic acid, whether synthetic or not, all nucleic acid material will be highly inflammable. See, all material, all drugs, all things which are nucleic acid based has to be inflammable. So they have to be inflammable. So they will cause inflammatory reactions. Okay. Now, why they are causing anaphylaxis is difficult to understand, because you cannot be allergic to a product without a protein. You cannot be allergic to unless there is a protein. So
Yeah.
therefore, they are now saying maybe the protein component of adjuvant they are using is causing the reaction and not the mRNA. So this we'll have to see now. In inflammation, yes. Nucleic acid will cause inflammatory fever, high-grade local reaction is expected. But how can mRNA produce anaphylaxis is difficult to understand unless they are using a protein to stabilize it, which they are anticipating. In that case, Moderna may not show that. In that case, they may modify their vaccine and take that out. That's my personal opinion. You cannot be allergic to anything other than a protein. And if this is a protein which they have made as a nucleic acid, I really don't know. I don't think so. It should be a protein.
So if mRNA vaccine is also a kill vaccine, then it should be safe.
It's not a kill vaccine. mRNA is not a kill vaccine. It's a synthetic, artificially made vaccine. See, you take the virus genome, and that is a lab-produced artificial genome which is introduced in the body. So it is not a killed vaccine. It is not a live
But
vaccine.
it's not a live vaccine.
No, it is not a live. It is not. It is not live. It is not
Synthetic.
killed. It is a synthetic vaccine.
Synthetic vaccine.
So I will explain you other way around. That you take a snake. If you keep a snake in Ramesh Datta's clinic, and if you keep a dead snake looks like alive in a Ramesh Datta's clinic, and if you take a snake and repair it and put it in Ramesh Datta's clinic, or if you cut the snake and put it in Ramesh Datta's clinic, or if you put only the head in Ramesh Datta's clinic, or if you make a synthetic snake and keep it there, looks like live, the response of the staff will be the same. That's what the business of vaccine is. They will immediately call Ramesh Datta and say that we have seen a snake in your clinic. The first reaction will be saap aa gaya. So that's what they are doing. Either they will do a live vaccine. So saap aa gaya hai. So that's what the reactions are. So I still feel that Moderna and Pfizer vaccine will be the best. But now I'm worried about a couple of things. Can this be given to people with underlying inflammation if it is causing more inflammation? Can it be given to underlying people with allergy? The time will tell us. So at this moment, everything is hushy-hushy. We don't know.
So as far as Covaxin is concerned, I think as far as the Indian climate and our refrigeration facilities are concerned, I think Covaxin is the best.
As on today, it's the safest.
Yeah.
There's a difference between it's the safest.
But in my opinion, it should be given in multiple doses.
Also, sir.
It can be given multiple times. It will be cheaper. It will not be costing more than 50 rupees or 100 rupees. It's a cheap. I will just show you one thing. I want to talk about which they said how can this be allergic. They said no. This is subsequent clarification gone into people of history of serious allergies, not the simple allergy. But what about asthma? And they said this can be a part. Which part they said there can be? They specifically said, they said that they use different types of fat particles, for instance, to coat the mRNA, but fat cannot cause a reaction. They are similar but not identical. Among those participated, I'll have to check which part they are saying which can cause allergy and not the mRNA part. So let me tell you one thing. Let me tell you one thing is that if you take a vaccine, go back to the history of smallpox vaccine. Go back to the history of smallpox vaccine. And they used to start, that is called as varroculum. What they used to do was a person who was positive, they will take the secretions of that person and they will take a needle. They will take a needle, put it into the secretion and put it in their body. So they used to do a natural they used to produce
Vaccination.
natural vaccine.
Antibodies.
That's how the origin of vaccination came in India. People started thinking about it is possible. Now, what people do in villages, is, and what people do in veterinary. In veterinary, what they will do is, so you take a patient sample of sputum, okay? You put it into, you inactivate that sample. When you do RT-PCR, you first inactivate the sample, okay? So first you inactivate the sample. What is that sample? When you do a RT-PCR, you take the sample.
Nutrition.
Yeah.
Nasal.
It will have protein and nucleic acid component. Protein and nucleic acid components.
No. You take the virus and you put it into the first test tube.
It will be lysed. The virus will be lysed.
No, virus cannot be lysed. How can the virus be lysed? That is done later to convert RNA into DNA. That is the second process. The first process, they take it into a liquid, which makes the virus inactivated.
I see.
It's an inactivated virus. That's what Covaxin is. So what the only difference is in Covaxin, they are culturing the virus and putting it in the same medium. The vaccine is ready. What is Covaxin? So if a husband's sample is put into alcohol and the wife says a drop of that I will drink, it becomes a oral vaccine. But to say it is safe or not, it takes 1 year trial. But Covaxin is nothing but a kill vaccine. You kill the vaccine by either irradiation or by some chemical or some alcohol. These are killed, they are all killed, they are killed vaccine. Now, killed vaccine in your body, when you say my RT-PCR is positive, when you say my RT-PCR is positive in the blood after 9 days, that virus should be working as a vaccine because now it's a killed virus. Continuous presence of that virus should be immunogenic and producing antibodies. So I personally feel those people whose antigen lasts longer, their antibodies should also be lasting longer because that's working more like a Covaxin in them. So we are only hypothesizing these things. So killed vaccine, there are trials going on in lung cancers. They are eradicating the cancer cells. They take the cancer cells, which contains the virus. They eradicate that cancer cells and use it like a treatment for the same patient. So what I'm going to say is there are lots of unanswered questions still unanswered. Lots of unanswered questions still unanswered. But I still feel in India, Covaxin will be given to much more people than, because what will happen, what I expect is after the Oxford is given, some people will start developing facial palsy or other things. People will not be able to differentiate whether it is due to vaccine or is it due to natural phenomena. And by the time if Covaxin comes, so Covaxin may take a lead. We don't know.
Yeah,
ultimately, it is for the WHO, CDC, and Indian government to ICMR to decide and lay a policy, what should be done. But as on today, we don't know. So let me now, because the time is 40 minutes, we had decided to do 45 minutes meetings. I'll request Jaya Krishna to full final comments and then Dr. Ramesh Datta to propose a vote of thanks. Jaya Krishnan is...
Dr. KK, one question from my side. If a person develops pulmonary fibrosis after COVID infection, so how to proceed to minimize that, that sequelae, you can say, or the complication of that disease?
See, most of the patients I am seeing, their fibrosis is dissolving over a period of time.
Right.
Okay, so let's treat the patient and not the report. We are treating CT scans aggressively. But most of the patients who CT scan shows fibrosis, they are showing good pulmonary functions. So they may recover over a period of time unless they have underlying immunological disease which is precipitating underlying ILD. So at this moment, I think after 6 months, we will say that all interstitial lung fibrosis by this is semi or completely reversible. We are seeing, I have seen a large number of cases, CT scans becoming completely normal who were labeled as fibrosis sometimes back. Now people are saying this is because of perfenidone, but that can't happen. Perfenidone can only stop the progression of IPF and not improve it.
Right, right. So thank you very much. With these words, I thank on behalf of Indian Medical Association, I thank Dr. K.K. Agarwal for interacting us with such a novel ideas and the progress of the disease and its treatment and about vaccine, what vaccines we can give to patient and what will be their complications afterwards. I also thank Dr. Rahul Pandit, though we could not hear him more because of poor connectivity. But whatever he has said, we have learned from his experience in Mumbai. And in the end, I thank once again Dr. K.K. Agarwal, who is my guru, and I am learning a lot. And today also I learned a lot from him about the vaccine, incoming vaccines in India. So with these words, I once again thank Dr. K.K. Agarwal once again and again and again. I am telling you, and Dr. Jayakishan and Dr. Sanchita for joining us and the team which is working behind the curtain to make this webinar a success. Thank you very much.